Thank you very much. My pleasure to be here. I've learned a lot already. It's a great opportunity to meet with colleagues and leaders in the field. I always enjoy getting together. And contrarians, as Dr. Dye, a little bit contrarian, like you said, a little bit different way of thinking. And I always learn so much from people who have ideas that challenge kind of accepted dogma. And like I say, for myself at the time, it was pretty old school to consider casting me, but I think it may have done me more good by letting me rest and get metabolically healed. Well, we'll talk about obesity, which affects all of our practices. If you're in orthopedics, if you're in rheumatology, this is a significant epidemic that we need to deal with. And really how we treat it, how we handle this. I served on the President's Council on Physical Fitness and Sports for 2 administrations, and this was the number one thing that we dealt with during the time of my service. I have nothing to disclose, and we'll try and really just get a handle on really what's happening today in the global epidemic of obesity. We'll discuss specific effects of aerobic exercise, strength training, and exercise effects independent of calorie restriction, too, on obesity to see, can we make a difference in this epidemic? The problem, well, about 70% of American adults are overweight or obese, and in less than 30 years in kids, the incidence of obesity has tripled. So it's significantly a diffuse problem in all age groups. And do we have sound on this? It's kind of bad. No sound?
Whoa, that's not good.
Oh, I don't need this. I'm already late.
Somebody will come.
Very typical.
Telephone.
No. Sorry. Somebody! Hello? There are 2 people stuck on an escalator and we need help. Now, would somebody please do something? I don't believe this. You gotta be kidding me.
I'm gonna cry.
Well, nothing else left to do.
So it's bad, right? Animals, too, are having an obesity crisis. This was just in USA Today, how heavy our pets are getting, amazingly enough. Striking statistics. These are causes of death, and as you can see, number 2 only to tobacco. Actually, later data now is showing that it is number 1, surpassing tobacco. Sitting time is an independent risk factor, and this is very interesting, that even if you get the recommended amount of exercise, again, our 150 minutes of moderate activity per week, if you sit a lot during your day, you will still have a bad metabolic profile. So sitting time is actually, it's independent from the time you spend in activity. If you spend less time sitting, you're going to have a healthier metabolic profile as far as lipid profiles, blood glucose profiles. We all know the dangers of sedentary living, and you can see them listed here. Obesity, type 2 diabetes, a lot of cardiovascular disease, and certain cancers, as well as mental health, depression, anxiety, many sleep quality, tons of things influenced by the fact that we are not active as a culture and society. There's many reasons for this. Certainly, we were talking in the dais earlier, just technology, affluence of society, accessibility of fast food, but these multiple factors combine. And again, this is not a genetic issue. We can see this is obesity trends when data was first being recorded in 1985 by the CDC. As you can see, the highest category there is 10 to 14% in some states. This is 2009, and here we're up to greater than 30% of some states. 2010 again, more states greater than 30%, so greater than 1/3 of the state has a BMI. This is measured by greater than 30. 25 to 30 is overweight, greater than 30 is obese. And again, BMI is not perfect, but it is a good screening tool to show us which way we're going. And this is the latest data from CDC. So, you know, it really, this is self-reported data, actually. So we really, and you see some studies showing, well, we're making a difference. We really aren't when you look at it. There's population bias in some of the later studies that have been reported. Lancet did a wonderfully elegant study in August of 2011, and you can see there the data that, again, we're not making that much difference in this in a positive way, that obesity rates will rise to almost 50% of men and women by 2030. The cost, $66 billion per year, and the disease burden, all the consequences, which we see in orthopedics and rheumatology, right? But also the metabolic problems of diabetes, certainly the cardiovascular problems, the strokes, the cancers. I just came back from China, where you wouldn't think this is a concern, but this is actually now a major health concern in China. In some cities, 20 to 25% of the people in China are obese. And this is unheard of in the country. And again, as they adopt more Western habits, Western lifestyle, Western food, technology, affluence, the same thing is happening in China. And striking statistic, the World Health Organization states that we've crossed the Rubicon. There are more overfed than underfed people in the world today. Not that there still isn't gross hunger and poverty problems, but if you look at the whole world as a whole, there's more overfed people than underfed. First time in history that's ever happened as far as recording this data. Things we don't want to be number one for, we are in the United States. We're the most obese country, and as you can see there, but rates are high in a lot of countries in both Europe and elsewhere. This is the prevalence of obesity, both sexes, 2008. You can see greater than 30 is red, and you can see, again, 20 to 20, actually 25, 30. A lot of the countries are in the category of overweight or obese. My own home state follows about the national average. About 70% of our state has a BMI greater than 25. And really, we're seeing this in our athlete population also. The picture there is in the Chicago Bears is the Fridge. He used to be the model for this guy who was so big he was called the Fridge. Right now, he would be a small lineman on a football team now. That's how the NFL has even changed. And, this is a workman's comp journal, the NFL's surprising occupational hazard, obesity that kills. And you can see the amount of NFL players have class 1, 2, and 3 is greater than 40 BMI. And this is not just due to increased muscle mass. Again, this was factored out. Again, if you have increased muscle mass, that's going to affect BMI. But this was independent of increased muscle mass. And also the related concerns of obesity, sleep apnea, hypertension, diabetes, coronary artery disease, and what we deal with a lot of degenerative joint disease from excessive load of tissue. The morbidity of obesity, well, type 2 diabetes can result with a weight gain of just 11 to 18 pounds. Again, for this group, osteoarthritis, for every 2 pounds of weight increase, there's a risk of OA increases about 9 to 13, on average 10% increase for every 2 pounds. Pregnancy, obesity increases risk of, as we all know, gestational diabetes, complications during delivery. This is striking. This is not morbidity, this is mortality. It's a wonderfully done study in the New England Journal of Medicine in 2006. And looked again, tried to factor out this is all-cause mortality. If you have a BMI of 30 to 34, you have a 200 to 300% higher mortality than normal weight adults. If you have a BMI 25 to 29, it's 20 to 40% higher mortality. Striking. Every conference I go to everywhere, people come up to me afterward and say, Doc, I knew it was bad. I did not know it was this bad. It is this bad. There's 20 years life loss due to obesity in certain age and ethnic groups. The cost is significant. We're trying to refine and revamp our healthcare economy. You can see the cost there. When we combine it with type 2 diabetes, it's about a $250 billion problem. And if obesity care, as you can see, for each adult, about 1/3 higher than for a non-obese. So we're really finding it more expensive to treat than alcohol and tobacco use. How much is a healthy weight worth? Well, in companies that have implied wellness strategies and obesity reduction programs, you can see the decline there in both hospitalization and medication use and incidence of treatment of high morbidity disease like cancer, joint problems. That's what our population is involved in a lot, about $1,000 a year in physician visits. Interesting, Dubai offered a gram of gold for each kilogram of weight loss in a 30-day challenge. So it's, again, this is Dubai having this challenge. So this is a worldwide problem. It's not just the United States anymore. At the Mayo Clinic, we've looked at our population. We have a healthy living center, which we're trying to make a difference. We have a whole wellness approach and a wellness committee at Mayo that are making a lot of changes as far as even meetings, having walking meetings, having wellness coaches, having healthy food choices, and marginalizing the choices of bad food choices. So we're trying to make a difference in that. But you can see the cost of obesity. And when we look at it, it's similar to George Washington University did another large study and found similar findings to us as far as smoking is $1,300 a year, but obesity almost more than smoking to treat. Again, is it genetic? Well, there's probably some genetic component. But as you can see from the CDC data we showed, that's not genetic, that's generational. And interesting studies, physical activity is associated with a 40% reduction in genetic predisposition as measured by the number of gene risk alleles. So actually you can modify your gene state by actually becoming physically active. And when they studied adolescents who were active, they actually overcome the effect of obesity-associated gene polymorphism and obesity-related traits. So there's actually a structural change that's happening, a genetic change from activity. Dean Ornish did some great work in Lancet, published in 2008, said that there was increased telomerase activity and increased telomere maintenance capacity in human immune system cells with lifestyle modification, dietary modification, and activity institution. And we're finding out more and more in the research, there's a mechanical stimulation that probably occurs that actually provides the stimulus for stem cells to change into lean tissue rather than fat cells. So the physical activity drives that, whatever modulatory factors, to differentiate into the lean tissue rather than fat. So we've seen the problem. Obesity is a problem. It's the American Medical Association now recognizes obesity as a disease. So how do we treat it if it's a disease? And our current guidelines now are 150 minutes of moderate activity a week, 75 minutes of vigorous activity, so about 30 minutes, 5 days a week. Interval training is effective, and even in older populations now we're finding the benefits of interval training. You can accumulate activity throughout the day, so it doesn't have to be all in one bout. We talked about the dangers of sedentary living. You want to be moving throughout the day. Strength training should also be included. So these are the general guidelines that people get. But when we look at the evidence and what works, does activity really work? We have a program now in the American College of Sports Medicine called Exercise is Medicine. And it's true, the effect of exercise, if we could bottle it and make it a pill, would be the best-selling pill out there, activity and exercise. But it's very hard to study what works in treating obesity because, as you can imagine, there's so many variables. There's dietary intake, there's the study design itself. How long was the study? How much did they follow them? Was there study bias? Did they adhere to the program, which is huge? As you all know with your patients, compliance and adherence is one of the main things we deal with. And really, what kind of exercise did they do? Was it only aerobic? Was it aerobic plus strength? How much of each? What intensity were they at? So very, very hard problem to study. We have to change, though, the energy balance. We have to have less calories come in, and we have to expend more calories going out. So if we look at aerobic exercise as a whole, if we look at studies that look at weight loss, we do lose weight with institution of just aerobic exercise, but it's very small unless we combine it with calorie restriction. So it's about 3% of the weight loss is just exercise alone. So if we are active, that's less effective than diet alone, actually, or diet certainly plus physical activity. So the take-home, physical activity alone has not been proven to produce significant weight loss, but especially in those dosages that are recommended from evidence-based data of 150 minutes a week. And that was, when I was on the President's Council in 2008, we helped formulate the physical activity guidelines, and that was based on the culling of the literature and meta-analysis of thousands, actually culled down to about 600 of the best articles, and that data was gleaned from that. So, but that data, that amount of activity alone is not solely responsible for significant weight loss. Single bout of exercise reduced very low density lipoproteins by 30%, so there is some acute effect of exercise. Acute exercise is superior to calorie restriction in lowering blood lipid levels, at least over the short term. So again, even though we may not be getting the weight loss, we're actually modifying the metabolic profile, and lipid profiles are changing. About 2 hours of physical activity to see this effect. 30 minutes is not enough to improve plasma triglycerides. So again, it's a lot longer than the guidelines that you hear out there and the guidelines we may be saying to our patients. You do have to be careful, though, because sometimes the equipment that you tell your patients to buy may be defective. Yeah. So, that's ouch. Oh, anyway, but a little humor though. But but how about in preventing weight? And that's another thing. Sometimes we have these people. There's a lot of recidivism, and people kind of regain the weight that they lost very quickly. So what about activity and weight gain prevention? And studies have shown that you need about 300 minutes per week of moderate intense activity. So that's about an hour a day for 5 days a week to maintain normal weight and prevent weight reaccumulation. So that 150 is not enough. And if there is a high BMI patient that you have, that is going to also probably require the 300 minutes per week of activity with dietary modification, so not just the 150 minutes. So to maintain weight loss and to keep weight from coming back on, and also for high BMI people starting in a program, the volume of activity needs to be much more. It makes sense. In a BMI over 40, there's initial weight loss greater if physical activity is included at the start, but similar at the end of 1 year. So we're finding, again, that pattern of you need the calorie restriction, you need dietary modification. Exercise alone can't do it. But, again, what we're seeing is if we add an activity, we change metabolic profiles. So we have a reduced abdominal fat, hepatic fat, insulin resistance, blood pressure, greater reduction in waist circumference, which is an independent factor of morbidity and mortality, greater weight loss with physical activity. So it's synergistic and additive. But again, compliance is one of the keys, and as you know, with any diet program, one of the problems is people aren't able to keep the weight off. So, one study actually gave people treadmills after an initial weight loss program. People did well. They gave them the treadmill, and even then, they could not sustain the weight loss with a free treadmill. So, there's been a lot of strategies, a lot of behavioral modification strategies incorporated to try and maintain weight loss, but it's very difficult. High-intensity training is a very hot topic now and being researched a large amount. And really, it does seem to have a very good effect on body composition, conditioning, VO2 max, glucose levels, blood pressure. Some studies show it's more effective than moderate intensity training in producing beneficial changes. A lot of the studies that we're seeing are small, short duration, often in young, fit individuals. There are some studies that show high-intensity training is very well tolerated, even in the cardiac population. And a lot of cardiac rehab programs are introducing interval training into their program with very good success and very low morbidity. So again, this is a topic that's going to be more researched in the future, and we all want to know how little can we get away with, right, to do the beneficial effect. And this may be a way of doing little, doing it harder, but short duration, more beneficial response. Improve longevity. We don't know yet, and reduce disease risk. We have the data with 150 minutes from all the studies that have been done. It's unclear whether we're going to get those same effects with the high-intensity training. And it does not seem to stimulate muscle building. Resistance training and weight loss. Can we just make a difference with resistance training alone? We lose about 10% of our lean muscle mass per decade after age 30. So by recouping the lean muscle mass, that's a good thing. So resistance training does increase lean muscle mass. It also, like aerobic exercise itself, has metabolic benefits. And resistance training itself decreases LDL cholesterol as well as insulin sensitivity. But again, in the absence of aerobic activity, it doesn't alone increase weight loss. So again, it has to be applied in tandem and in synergy by itself. It's not the whole answer. Metabolic profile seems very benefited by strength training and resistance training. And this doesn't matter if you do it with tubing or free weights or body weight. Any kind of resistance training produces these beneficial metabolic changes. And in people with coronary artery disease, nice studies showed that strength and aerobic training was more effective than aerobic alone than improving body composition. It only makes sense. All of us are losing about 10% per decade of lean muscle mass. If we don't replace that, muscle is the engine that burns calories. So by replacing what we've lost over time, we're going to make ourselves more efficient in burning calories. So take-home messages, we're in the midst of a global obesity epidemic. Low physical activity levels are related to weight gain and increased risk of cardiovascular disease. If we're active, we have reduction in healthcare costs, missed work, hospitalizations. We got to watch our sitting time because even just sitting alone is an independent risk factor. Exercise itself has a small independent effect, typically less than 3%, but significant additive effect in synergy when combined with dietary modifications. Exercise can help sustain loss, especially if it's more in the realm of 300 minutes per week. Strength training by itself is not shown to produce significant weight loss, but again, if we combine it, it increases lean muscle, produces beneficial metabolic effects. And again, even in the absence of weight loss, again, getting the focus out of a number, I have to get to blank pounds. Just being active is going to produce beneficial metabolic effects in our body, including blood pressure effects, lipid beneficial effects, and insulin beneficial effects. So one of the goals at the American College of Sports Medicine now is really a paradigm shift, just getting people active rather than we're in the midst of this epidemic. But if we focus on a number, some people say, I can never get there. I should be at blank. Oh, man, they get demotivated, they don't do anything, and we've lost them. But I think if we focus on physical activity, your BMI may not be exactly where it should be, but you can actually be healthy and have a beneficial metabolic profile by being active. That gentleman at the bottom, as an example, he has a BMI of 40, but he's competed in 276 triathlons, a lot of them Ironman distance. So again, he's at 40, but his metabolic profile, he's fit. So not that we don't want to make an overall difference, but I think still, I think we demotivate patients sometimes by giving them these goals that seem unrealistic and are very long-term. And sometimes when you're right in it, you don't see the long-term, and you can't get motivated enough to get to the long-term. But if you get them active, you'll have these beneficial effects that then will serve both purposes. So I thank you very much.
Are there any questions? We have a question from the panel up here.
Okay, thank you so much, Professor Laskowski. This is a really very crucial topic and one very dear to me. I'm just wondering what your group is doing to possibly advocate to overcome the low physical activity levels in schools and among young people, since all of these studies have been done on adults who may already be challenged, and we know the earlier one intervenes and adopts healthy behaviors and norms, these are more likely to attenuate obesity in the earlier years, as well as to enable people to carry out healthy lifestyles as a norm as opposed to an add-on.
Yes, thank you, Dr. Marks. It's an excellent point. Childhood obesity is certainly increasing, and the likelihood, if you're obese as a child, 70 to 80% likelihood you'll be obese as an adult. So early intervention absolutely is very key. Again, a lot of factors. I think legislation is part of it. Our school districts have been cutting out physical activity as part of the school day, so getting it incorporated again. The reason, it was funny, when I was appointed to the President's Council on Physical Fitness, I started looking into the history of the council. Well, the history of the council started in the 1950s with Dwight Eisenhower, with a report that came to him, plopped on his desk, saying, look at Europe's kids' performance on these physical fitness tests. They're killing us. They're much healthier than we are. We're not doing anything about it. So that's what got physical activity actually introduced into the curriculum, into the school system. So we need to advocate for that. I think that technology and screen time, I think parents are a huge part of this. And really, I think you are a role model to your kids. We really see the family effect. And, We talk about honesty, and then the phone rings, and we say, tell them I'm not home. What does that say? We think about honesty. Well, we can say, I had this great lecture about obesity and activity. We should be active and all that. But if we don't model it, they're not going to do it. So I think it really starts at the home. And one of my focuses on the President's Council was getting the family involved. And after dinner, we go out, we walk, we talk about the day's events while we're walking. We bike together, we hike together, we ski together. We do a lot of stuff together that is active. And I think our kids now, it's just, again, habit is what you do. Our kids will do this now. They'll do this. It's woven into their life, so the activity is a part of their life. It's very hard when you've never done anything to try and then reinstitute it. So if we can weave activity into our families, we can try and make these legislative differences in the schools, but I think it's incumbent on each of us to have our sphere of influence. And we are a role model at Mayo. We have these wellness coaches. And it's amazing how when one person even in a secretary loses weight, the other secretaries are, oh, what did you do?
Diffuses into the community.
Exactly. Mm-hmm.
Sorry, I just have one other point. There's a lot of research now on, as you say, physical activity in the schools, but leading to higher academic achievement and correlated with obesity and lifestyles. And I'm wondering if you're using that with the parents to encourage less reading, writing, and maths, and to reinstitute physical activity, not only in their daily lives and the weekends, but to argue at PTA meetings for physical activity to be a core subject and to be taught by experts in the field.
That's a great point, Dr. Marks. Yeah, that's exactly true. And we have voluminous data to show that task performance, thinking efficiency, skill at completing assignments is all improved in an active population. So that is used too. We're trying, some of you may know Jim Levine. He works at Mayo. He's now in Arizona, but he was the originator of the standing desk and the treadmill desk and all that sort of stuff, and the NEAT, non-exercise activity thermogenesis, just getting people moving. He's actually got a device in kids that you have to kind of cycle on the bike to get the screen to come up. And we're trying to pilot in our school district now that with the school that uses computers for some of the classes, that to get that thing to turn on, you have to be moving. So in the classroom, the kids do an exercise to get that thing to happen. So it's a good point.
Questions in the back?
Great presentation, and clearly burning the calories is the way to go primarily, but there are other approaches to this that I've read about. For example, altering the gut flora from people who are skinny and taking that gut flora from skinny people to overweight people, and I've read some work on that, and also, of course, lap banding. What are your opinions on that approach?
I think there's a lot of neat research, as you point out, Dr. Dye, a lot of neat, exciting things coming in the future. But, going back to the foundation, I go back to that CDC graph profile, that this is a generational phenomena, that I think we just need to get more active, and our culture's doing it to us, our technology's doing it to us, our affluence really is doing it to us. We couldn't even buy it. We were just talking. I never went out to eat when I was a kid. We couldn't, fast food, that was incredibly rare. Now the whole country is eating because we're busy and we have stuff to do and everything. Your
point is clear. Mm-hmm. I agree with it totally.
So,
but what about the gut flora thing? Have you have an opinion about that?
Well, I think it's
that a real thing or not?
Well, I think a lot of these have potential. We have to look at the long term and see what a lot of these things that seem to be effective. When we look at them long term, we get almost the same thing as dietary intervention, which people go right back up. So we have to: is it sustainable over time? Does it work in all populations? Is there genetic, there's probably a portion of people that are going to respond to that better than others, and do we identify that? So I think the work is ongoing, it's exciting, but again, I'd go beyond that and get back to the more foundational stuff.
Mohammad Hassan from University of Alabama. My simple question is the seating habits you talk about. Like when we were postdoctoral fellow working on the bench, and then when become faculty to just lead the research team, there is a huge transition happens on your metabolic profiles anyway. So what do you think, like how we can utilize our seating habits to keep our metabolism or to keep our metabolic profile?
So what I do now with our teaching rounds, we have a little placard that says walking meeting in progress. So I'll take our residents and our fellow and we'll just walk. Instead of sitting in the conference room, we'll actually be walking during our rounds. you know, and we'll just try and keep moving as much as possible. Our workday is pretty busy, so we're usually up and moving to begin with. But those things where, you know, we're sitting in a lecture hall for a long period of time, like here, we encourage standing. All our lecture halls have a back row where you can stand and just move around during the lecture time. So those are simple little things, and the walking meeting thing works really well. And it's, you just wear a little placard, say walking meeting in progress, so people know that you're doing something, you're not just walking around. And you know, we've had great success with that, because oftentimes you'll have a dedicated 1 hour time, say you're with your fellow or your residents or whatever, and use it when you're up and moving. A beautiful day, you can be outside, enjoy it. That does a lot for the psyche as well. So,
Dr. Laskowski, I'd like to ask a quick question. The thing that strikes me about the talk is you say that you can do a lot of this exercise and whatnot, but if you're sitting for long periods of time as part of your job and your livelihood, you're going to have a problem. Is this something that some other I mean, you sit on the President's Council. I mean, is this something that the executive branch can start making recommendations, say, through OSHA, where if you have office workers who the paradigm today is that they sit at a desk and type on a computer, can they forcefully change those work environments to promote something like this?
That's a great question. I wish we were to that point where we could have that impact from a more, you know, global scale. Right now it's up to employees, and as you know, these are expensive. You know, a treadmill desk is expensive to get. So even in our own facility, you know, oh man, I'm not going to get one of those. You know, we do have standing desks though, which are a lot cheaper. Right. And those are pretty easy to incorporate. So if your company, work groups who are trying to make a difference with the ergonomic people who are at large companies, and I think if that takes effect, and we can prove some of this research, as that begins to pile up on the deleterious effects, that'll hopefully drive a more global change in that area. But
good. Glad to hear it. Are there any other questions?
Any more questions? No? Good, thank you.
No, thank you very much, Dr. Laskowski.
Thank you.